She works right in the middle and finds compromise.
Especially when it comes to protecting things here in Missouri.
At the KSMO studios, it's time for us to sit down with Hospital Administrator Kasey Lucas on this Thursday morning, and he's trying to readjust his chair. I don't know. There's only two of those. There you go. So I only say a couple little.
Hey, last time I broke it. So.
Yeah, you did try and break it, but you didn't quite do it. But you did try. That's all right. I can go steal one from the hospital and replace it. Except you guys don't get the same kind of chair, so it would be tougher. But anyway, nonetheless, we got Hospital Administrator Kasey Lucas with us, and good to have you on the regular day.
Yes, it's good to be here.
You forgot how to do that.
Yep. First out of the last 3 months, we haven't had to reschedule for a different time.
You'd have to go to Washington, D.C., or go down to an MHA meeting or some crazy stuff like that. Anyway, but it's good to have you. Anyway, we appreciate Kasey coming in and spending some time with us and going over some different things that goes on at our hospital, keep you up to date on what's going on. And Kasey, we can honestly tell people that the hospital changes each and every single day. You guys just keep making different changes, improvements, add-ons, updating, and that includes not only the physical plan itself, but some newer people have come in, and it really has been interesting. We had one of new pharmacists in here the other day,
yes.
I guess 2 weeks ago, Brett.
Yeah.
He was in, and we talked a little bit about the flu, getting your vaccines and things of that nature. Very nice gentleman.
Yes.
Very smart, I might add.
Yes.
Almost too smart for his own britches, but very smart guy. But you still have some of the old standards. People have known for years. Cindy Fry came in at this last meeting, along with Amy Thompson, and kind of went over some of the different things that are going on with some of the patient rooms and acute care and the, let's say, communication between nurses, doctors, and patients, just to get the board up to date. And this is a new thing that you just started last month, in bringing people in and letting the board hear from them, not from
not through us. Not through
Right.
us. I mean, they need to come and I think that's good transparency all the way through from the frontline directors to the board. And again, it's a time they get to know them too. So,
sure.
They usually get there 30 minutes before the meeting. We, eat, have dinner, and they get a chance to talk and get to know each other a little bit better. And again, I think that just creates just a better atmosphere for them. And if they needed to go to the board for something, or if they, saw them, or they would know who they're talking to and what's going on. So.
And also gives the board a chance to ask them direct questions, which is good because sometimes they see something and say, hey, can you explain this to me? And now they can get a full explanation because they may just not understand, and they can come and ask you, and you can say, well, this is probably what they're doing. Well, that may not be what they're doing.
Right.
You may be assuming that's what they're doing. So, but this was a very nice presentation because there are a lot of changes being made.
Yes.
And you want to touch on some of them?
Oh, yeah. In surgery, I mean, I think there was, she went through a long list, and we had some pictures that went along with this, and you could just see the facility. One thing we didn't do, and we thought about later, is, man, we would like to have those before and afters.
Yeah,
we didn't do that, but
we've done that
there
too.
was a couple of areas where we could do a before and after, and so we did that. But it's just bringing, like you said, the facility up to date, trying to make some improvements, not only to the plant and equipment, but to processes as well.
Sure.
And another thing that Amy mentioned was some of the paperwork that we used to do on paper. We've transitioned some of her things now to the EHR. And that's in this time. You would think everybody's on the EHR now, and there's still just a few areas in the hospital that are not on the EHR, and we are trying to transition them there, but also transition them when it makes sense, because sometimes you can force this into the EHR, and but is it really the result you want to get it? And sometimes it's not. So
if the fit's not right, you can make things worse.
Yes.
So timing is a big thing, but also making sure that in doing that you're making it more advantageous on everybody and not creating a deluge of additional work.
Yes.
We did this, and I think we made a mistake, and now we're gonna have to go back and start back over again with the last month we just did this new system. We're going to have to replace it all with the paperwork again because we don't know what happened to it or whatever.
Yes.
So you definitely want to make sure that you've got everybody on board, but also that the process is going to be simple enough for everybody to work out.
Yes. And so, we went through some of the equipment purchases, just changes to the facility. I think Amy had mentioned it was a
I wasn't there.
a water processing unit in the surgery, and that unit now is it had aged out several years ago, but again it continued just to be in the facility, and so earlier this year we've pulled that out. Got that out of there, and again you can use that space. That's usable space now for something else, and so. And that was one of the things. I mean, we were talking about space. Space is at a premium in the hospital, and every time we do something or try to add a service, those are concerns. Those are things that we look at. So in surgery, it was really the facility. Some of the updates. She showed a couple of pictures of the new recliners and areas that we use those recliners.
Right.
She showed a picture of the stretchers that we are using now from the pre-op to surgery and then back and forth as they come back over for post-op.
Right.
And so.
Some of those are brand new stretchers just came in.
Yeah, at one time those were we did all of that by wheelchair.
Right.
So that was a new process for us too, and something that we thought, the better care, better quality, safer care that we could provide patients. That was definitely what we wanted to do. We got into acute care and with Cindy Fry, and she brought up. Again, I think some of the patient chairs and the recliners that the foundation had purchased and we had raised money. The foundation raised money for those, and so she talked a little bit about that. She really a big part of her discussion was processes, and we did talk about the whiteboards because we have new patient whiteboards, and what these whiteboards do is they are positioned on the wall at the foot of the bed of every patient bed, and they have a lot of statistics, a lot of information, patient name, this, that. Really, what they like to key on is there's a section that's goals, okay, and so. Everybody that's involved in that patient care understands the goals that this patient has for the day, has for the week, has for discharge, because we start that discharge planning the day that they're admitted. We start looking and saying, hey, what's it going to take? What's the plan of care? We're in the results of that plan of care. Can we say, hey, we've met our goal. It's time to go through a discharge. And so we've looked at that. And that whiteboard's going to really help that process. We're going to put those in. We don't have them in yet, but we've got them in the building. We haven't put them up yet. Over the next probably 30 days, we're going to start doing that. But one thing that Cindy has done is those type of processes in her department is having at her monthly meeting is having specific time set aside to work on those processes. Let those employees have the input in how we structure those processes and how we come up with a solution to this issue. And so they've been doing this for some time, and the use of those whiteboards, that's going to be a process that they go through and they say, okay, how do we want to do it? Who's responsible? You have to create expectations for them. How is it going to get used? When's it going to get used? But also, one thing that has changed with just our rounding process on the floor is the physician that's rounding for the day. We've got a hybrid hospitalist program, so we have Dr. Jasmine Wall that rounds Monday through Thursdays.
Okay.
And then coverage we have Friday, Saturday, and Sunday. We have different physicians from the community filling in or from our staff filling in for rounding on those days. But we I'm going to say long time ago, when the physician rounded, we usually had at least a nurse going with the physician and rounding.
Sure.
And for some time, we got away from that. And it was just the physician going and rounding on the patients they're going to round on, and then they're done for the day. And just recently, that's come up of, hey, do we want to start this rounding together? I think the patients will benefit from that. They will have both providers. Again, you have those providers you see all day, every day.
Long, yeah.
And then you have your physician that comes in, rounds once a day on you. And when you have those two together and there's communication there and you can hear that communication, we started it just with the nurse and the physician. And in a few days of that happening, we had other disciplines, social services, pharmacy, asking to be included in that process. Because again, if they have an issue and their physician is rounding, to have those professionals right there with them, they can all discuss any of those issues. Well, how about this? Or how about this? Or I think we should do this. What do you think about this? Can we change this? Or do we need to do this? All of those questions can be answered and everybody understands the direction. Again, a lot of that can be gotten from the physician's note, but just to have the physician right there available and giving you real-time feedback back and forth is going to be fantastic.
So the change of that process is now being implemented, and,
yes.
and it's working better for not only the patient, but also for the hospital staff themselves.
Sure. And really, we didn't think it would get, well, right off, whenever there's change, you understand, people automatically resist change. And so we had a little bit of that, but I'm telling you, it didn't take long. And they saw the value in it and really, yes, does it take a little more time? Yes. But
sure.
Does it add value? Yes, it does.
Yeah.
And so.
And and that's what it's all about. When you go back to talking about every patient, every encounter, every time, and this is what it is. You want to make sure that patient gets the best care. The best care is not just having a person come in and maybe not totally familiar with their case, looking at it and just accepting what's been done. Now they got a chance to actually talk about it with the person who you might be seeing all day long. So, yeah, I mean, I like the idea, and I'm not even there. But, I can definitely see a benefit to the patient side of it, and I can definitely see a benefit to the nurse and the doctor side of it, because they're going to be more informed.
Yes, that's all.
Absolutely.
Yeah. That's really, and really, I think that's kind of Cindy's with her updates. Again, there's updating going on, renovating the patient rooms. I mean, that's going to be a huge project. Every time you take a patient room, I mean, if we took half the patient rooms and started to renovate, our volume would be limited to half the volume we could. So we're going to have to do that in a manner that, one, allows us to continue to see patients and the level of patients, the increased volume that we've seen. We're going to be, we're going to want to continue to do that too. So it'll be a room by room, 2 rooms by 2 rooms, whatever we can figure into this. Updating, just the overall look of the room, and updating. Like you said, updating some of that equipment and some of those things. So
when you think about that, and you have to put a strategy together, as you're mentioning, you don't want to curtail any services because you're trying to do too much.
Yes.
You still need to offer the same service and provide the same facility that these people need. That takes that will take an overall strategy of exactly how can we do this, and of course flu season's coming up. So the timing of this may not be optimal. This is not going to get done in 1 month.
Oh, no.
This is going to take a while. So when people say, well, yeah, we just shut down 2 rooms right now. Well, you know what? If we should have a flu epidemic, you can't shut down 2 rooms right now.
Right.
You might be able to get by with 1, hopefully get it renovated in time, and then may have to leave all rooms open again until you start to see that admission slow down. Then you can go back and maybe start to resume where you were.
Yes.
But the strategy has got to be followed to a T, because the hospital, I know you would not want to sit there and say, we're out of beds.
Right.
we're out of
Right.
rooms. I'm sorry, we're out of
Right.
rooms. We got 3 of them under construction right now, and so, we can't do that. And I know the hospital doesn't want to do that and turn away a patient. So it's very good, and you guys have already kind of put together this strategy already. I
Yes.
know you have.
Yes.
So it's not like I'm barking out something that's not already in place. But for people out there that may not understand, the hospital, you have limited beds already. To limit it even more,
Yes.
would be
Yes.
detrimental.
Yes.
And it could be detrimental to somebody's health if they need to be admitted now.
Yes.
Not wait and say, well, we'll see what happens. We got somebody that, they might be checking out here in a while.
Yes, yes. And just to look at, as we get into the statistics for this month, I mean, our average daily census was 10.
Yeah.
And just over 10, but right at about 10. And so you say, well, we've got 25 beds. Yes, but the average was 10. I mean, there was a day or two
Some
in
are
that we were up
longer.
to 18. And so, and
Some
that's
are
not
shorter.
even, that's not even up into the flu season.
Yeah,
so.
we're not even close to that. Just starting it, as a
Yes.
matter of fact, and hearing already about people catching the flu, which hopefully isn't going to be bad this year. It's just hopefully. And if you haven't had your flu shot yet, go get it. Go
Yeah.
get it. It's out there.
Yes.
Everywhere. You can get it at SMDH
Yeah.
Family
And
Medicine.
it's not,
you go there.
we understand it's not 100%.
It's never going to be 100%.
Never going to be 100%.
Because
But,
the flu virus mutates.
yes.
And it just continues to mutate. So it's never going to be 100%. But if it's 85% or 80%, that's better than 100%.
Sure. Sure.
Catching it, you just take it, and it will not. Basically, when you get the flu shot, the idea is it will lessen the severity
Yes.
of the flu.
When you get the flu, yeah.
Okay.
So
there we go.
there we go.
Now we explained it the same way
Yeah.
the CHC does, the CDC.
Yes. And we'll
All
have
right.
and we'll have more departments coming in and updating us on
Sure,
these things
sure.
in months to come. So
Very good. Well, speaking of admissions, it was a busy month, as you were mentioning. In September of 17, you had 47 admissions, and this time you had 111.
yes,
And 111, that's quite a number.
it is. It is. And we hope that as we get to some other statistics later on, we are trying to keep as many patients here as possible. And again, I think we're looking at expanding those expectations. What can stay, what has to go, what are we safe and comfortable sending home? What things do we want to? You'll see observation has picked up
Right,
from
I
last year to
already
this
did.
year, and so those
3
are things,
times.
Yeah, those are things that we want to make sure we're ruling out. Whether it's cardiac, whether it's stroke, whether it's whatever it is, we're ruling that out, making sure that if we need to keep you for 24 hours, under 24 hours, a little over 24 hours, whatever that is, just to make sure that your symptoms are being taken care of and we see improvement, that we're doing that. And so we're making better use of that observation status as well. But just looking at the med-surg admissions, 65 compared to 27 last year. So
I know, I saw that. Again, almost
and-
3 times the amount.
yeah, and patient days, as you can see, it's not as big but 304 compared to 177 budgeted and 193 for last year.
It's
You
not
can see-
proportionate to what you had
Right.
the previous year compared to the amount of admissions.
Yes.
So some
And-
people were admitted for a very short period of time.
And we see that with the observations. The observations, the more that we use that observation, the length of stay overall of acute care will be decreased.
Decreased.
Because they're staying less. If they stay 18, 24 hours, whatever it is, so that we, again, the patient gets the care they need, and again, we're not keeping them 4 days. We're getting them in and out in one, and saying yes, your symptoms have looks like they're getting better and being relieved, and we can let you go home now.
Right.
So,
And swing beds up too.
yes, yes,
So and 40% of your acute care was occupied. That's a pretty strong number for
Yes.
our Salem Hospital.
yes.
40%.
And that again, 10. I mean, 10 patients on the average But you have those days where we had 7 or 6, and you have those days we have 15 or 16.
13 to
So,
15,
yeah.
somewhere in there. And some of them stay a while.
Yes.
You know, until you see that improvement, you're not gonna be moving them too much.
Yes.
And you really don't want, once you admit them, you really want to make sure that they get healthier. Excuse me, because I remember when we talked a long time ago, is the last thing you want to do is dismiss them and have them be sick again at home and bring them back.
Yes.
You do not want to do that.
No.
That's not something you want to have repeat customers for the same illness that they came to be treated for. So that's
And we've started a little bit closer review with we've got a utilization review nurse, and he looks at the all of the criteria that it takes to admit a patient, and we make sure that we're meeting that criteria. And it fits in the mold of CMS and what Medicare is expecting for these admissions or observations. If it's an observation patient, does it fit in that mold?
Sure.
Making sure that, again, we want people to get the care they need, and we want to make sure it's in the right setting. So we're doing what we can there, but we are looking at those things, and those are very important to the patient, because, again, if I don't meet this or qualify and you have me staying, am I going to be ultimately responsible for this? And we don't want that. So
I bet people didn't even know you had that type of nurse.
No.
It's not something that you hear about on your ads.
No, it is
something that's discussed, but it's an internal control.
Oh yeah, it is definitely something to help us keep in compliance with regulations. I mean, it is one of those things that we've had forever. But
not talked about.
As we start to increase our admissions, or at least keep those patients we want to keep, and there's some discussion around that. How, what's the severity of patient we want to keep? Again, we tend to, we figure out what we do well. And if we can't do it, we'll get you where you need to be. But we like to keep you here if we can. And it's the benefit of the patient.
Sure, it's closer to home. Yeah,
sure.
It's more right here. So, but anyway, when you mention that, there's that thing, how many different levels there are to every single thing that goes, every process at the hospital. It's not a one-level process. It's not just Cindy Fry makes that decision, that's it. No, it goes here, it goes here, it goes here, it goes here. You may have 5 or 6 levels before, it finally is determined what to do with that patient.
Yeah, and you know what? And that's funny, because those are processes that are changing too for us. And that's, it goes from the emergency room physician to talk to the attending physician. The attending physician needs to make a decision what direction he's leaning. After we do that, we can talk to utilization review, and we have a service when Steve can't be available 24/7.
Right.
But we do have a service that covers him when he is not available, and we get a hold of that service and we say, hey, this is what we're thinking and this is why we want to do this, and they say, oh yeah, that meets criteria, or, well, make sure you do these things before you do that. But other than that, yeah, it looks good, and we want to keep that. That falls into the criteria. So,
it's amazing that people would never think of that when they think about being admitted. They think it's one person decision, and that's it, and it's not.
No.
So it goes through the process.
I mean, and I will say, but ultimately, it's the ER and attending physicians. Their decision to keep the patient. If we felt like it just wasn't safe for the patient to go home, yet didn't meet criteria,
right,
we may approach the patient and say, this is our thought. Again, that utilization review isn't the final answer. The final answer is the insurance company. Right. And so, we understand there's going to be times where things happen, and that's always up for administration review on how things like that get resolved. So we do that. But from a patient standpoint, patient safety standpoint, it's always the physician's decision. Do we let him go home? Do we keep him here?
Or do we transfer him somewhere else?
And again, the patient's involved in that process and has to be involved in that process. So
Very good. A lot more to it than just making a real quick on-the-spot decision. Oh, yeah, let's put them over here. Because you see it on TV, it's just, no, you don't hear it. Just
yes.
done in seconds.
Yes.
Nah, not really. Okay, well, let's look at some of the other statistics we have. And obviously, that was on the acute side. Outpatient registrations were up. You had cardiopulmonary procedures way up. Lab tests were up a little bit, but radiological procedures, again, way up. And then your rehab treatments have just continued to climb. And then surgical procedures, pretty much, you'd be around 25 to 35 a month. That's what is about normal. Home health, again, way up, and long-term care full.
Yeah. I mean, we had some things going on with some vendors. We had Run had a lot of their annual labs that happened, and lab or annual it's a physical annual physicals. So we did that, and we go down there on site and actually provide all that service on site. So we had a lot of that happening during September. We had the health screenings.
Right.
So down at the Armory. So we had that, and so a lot of things contributed to those numbers. But I like to see those numbers up, and really looking at the ED was probably down about 4 or 5%, but which again, that fluctuation is just natural fluctuation. So 788 compared to 812 ER visits budgeted, and or 812 budgeted. And see, I want to focus on the transferred and admitted. And you look at last year, we transferred 74, we admitted 36. This year,
kind of flip-flopping.
We admitted 86, we transferred 43. So it has flip-flopped, and we like to see that. Again, we want to make sure that we can provide that service. But if we can provide that service and keep that patient here, overall there's more there anyway from what's being the ER disposition is up no matter what. Right. But again, if we can, with that increase, if we can keep that increase, we want to do that. So
very good. Ambulance runs continue to run about 210 to 250 a month.
Yeah.
And usually it's about 60 to 70% of those have a patient transferred, but dry runs are still there. It's just part of the business. You're going to have them, even if, because you might get there, somebody's actually hurt. They may just take care of them right there, not that bad, instead of bringing them all the way back to the hospital. And other times you have to send 2 ambulances, or maybe even 3 to the same accident. It just depends on the accident. So, again, we keep that in mind. And some of those are just service to go and help people, and we've talked about that before. The operating statement did show a profit, which is always good. The inpatient numbers were good. The outpatient numbers were good. So, when you have good numbers, it's going to be good, right? Well, that's always good. Good's good. And you had an operating gain from operations of $63,475. And, of course, a little unrestricted tax never hurt anybody.
Yeah.
That helps. And it goes up a little bit, about $2,500 more.
Yeah.
So you're up there close to it's almost $66,000 on the good side, on the black. The interesting, when people take a look at these numbers, and they always say, well, you had all those people in there, but, a lot of those numbers aren't even in here yet. You get people admitted late in the process. You don't even have those billed out yet. So, you don't even know what those numbers are going to be. And so you're hoping the October numbers will reflect a lot of that, and then we'll see what happens there. But anyway, very good numbers for that. But when we look at the expenses, what do we see, Kasey? These expenses here, what is all this about?
Well, there's not really
nothing out of line.
I would say
supposed to say, Stan, nothing's out of line.
Supplies are up, but again, volume's up. When you get volume up, then you're gonna see an increase, and there's a little bit of salaries up, and some of that has to do with budget. And again, budget's only good at the time that you approve that budget, and as things change, it's going to change a little bit. But especially when you're bringing a provider on that you hadn't budgeted a provider, this or that, didn't have those things known for sure yet. So there's a little bit of that.
But everything else is in line. Your maintenance, your utilities, the drug costs, everything is in line. You know, you have budgeted. You know, when you look maybe at supplies at 165 versus 131 last year, but you budgeted 146, so you knew it'd be more.
Yes.
You know, your contractual services might be above, but your physician contracts are down. So
Yes.
there's a what I'm saying is,
There's
it's a
yeah.
balance
Yeah.
in what these are. And so when you look at them, if you have, let's use statistical analysis. If you have a plus or minus 3% off of your mean, of your deviation, that's pretty doggone good.
Yes.
For you start talking about $8 million, 3% deviation in dollars from what you expect. Case, that's pretty doggone good.
Yeah.
And in this case, the deviation off the monthly budget was $20,000.
Yes.
That's pretty doggone
Well, that's good.
You don't look at each individual, and you don't look at per month. It's just, that's not fair. Because you know as well as I do, you've got all these patients coming in September. You're going to have to order all these supplies. Some of these supplies you may have ordered at the end of September, they're going to come in October, and you got to pay for them.
Yes.
And that could ring up those supply numbers big time.
Yep.
And then all of a sudden your volume goes down. Well, okay. Well, then that reflects on the November and December statements.
Yeah. It does.
So
It does.
people have to understand it's not immediate. You have to sometimes be patient. That's why you look at it on an overall, on an annual basis.
Yes.
It gives you
Yes.
better. And even then, sometimes you have to look on a 2 or 3 year term. And when you do the budget, you look back, 5 years? Don't you guys look at 5 years?
Oh, yeah.
What
Yeah,
budget
yeah.
go back? So gives you a good full scope of what you're doing. Good. The balance sheet. I always like good, solid balance sheets. Now, check the cash is down a little
Yeah,
bit.
we
had a
did.
little
We had a
loss on
dip
the
in
cash
cash.
here in this past month, but I know people say, "How can you lose cash when you make a profit?" Trust me, you can. You got to pay for it now. You get it later.
Yes. Yes.
But it does happen. But still, Kasey, I always look at the numbers with the current liabilities at 1.4, and you got current assets of 8.4.
Yes. Yeah.
6 times 6 to 1.
Yes.
That's,
And
that's
you know,
just
and it's
fair.
And I will tell you, we usually, previous years, we've had the audit report in October. We had a scheduling.
Probably a good thing you
we had a conflict with scheduling for October, so yes, it's probably good that we didn't. And so we couldn't have it in October, but I have a draft of it, and pretty much final draft of what it's going to look like. And so I know some of those numbers, won't be able to report them until next month,
Right.
but. Again, I'm pleased with where that is, and we can continue to move in that direction. That'd be awesome. I mean, again, when you look at the operations of this month and up through this month this year, we're going to continue to grow that, and hopefully continue to grow other services.
Right.
So
there's a number of when we start, and not to tell any of you out there, some accounting term. He's talked about current ratio and different things, and capitalization and different things of that nature, which Kasey and I could probably talk about for a while. But but a lot of people won't understand all of that because they just, there's just certain ratios. If you don't know what's involved in those ratios, you don't have any idea what you're talking about. But those ratios sometimes are what you can't just look at numbers. Sometimes you got to look at the ratios. And when you look at those ratios and you see if they're climbing or staying steady or just within, you can, if you graph those ratios sometimes, it's pretty amazing the story they tell. Because you may think you have a great year, but then all of a sudden maybe your expense ratio in a certain area has climbed 25 or 30%.
Yes.
Yeah, you still may look good on the bottom line, but that's some concern. You need to say, hey, wait a minute, what's going on here? And that's why when you get all these reports from the accountant on your audit, you get these ratios.
Yes.
You see all these numbers, and you get to see things. And a lot of people aren't numbers people, but when you start to see trends, they get your attention pretty quick, Or if you see a number that's just out of place, that'll get your attention pretty quick. So, but the ratios are very important. We talk about ratios like days cash on hand.
Yes.
It's not truly a ratio. It's just a snapshot,
Yes.
a one-day snapshot of where you stand with your current cash situation.
Yep.
But it is a very important number to know where you stand because you need to know the processes. If you got no income today, how long do you stay open? That's really about what it means.
Yeah,
This is what you
yeah,
have
yeah.
on hand.
Yeah.
If not one dime came in, we could stay
Yeah.
going 67 days.
Yes. Yeah.
That's over 2 months.
Yeah.
That's not bad.
No, not bad.
How many businesses do you know can go over 2 months
Mm.
if they didn't get a dime of income?
Yes.
Not, and hopefully you would say every business I know could last at least 2 months, if not 6. Well, that'd be great.
Yes.
We know some businesses just aren't in that position. And hospital's in very good position, and we just hope that doesn't happen, that they'll get a dime.
Yes.
So
Yeah,
the
no.
67 days. And that's down from 2018's number of 89.
Yes.
And that's
Yeah.
3 months.
Yeah.
So, but still 67, a very good number, way over the average for rural Missouri and Critical Access Hospital, just about right on there.
Yeah, and receipts were a little low this month, and we've had some turnover in our business office. We've had some turnover in our medical records, and if you think that the revenue cycle is you put in charges and it gets billed tomorrow, that's not the way it goes in a
that would be
hospital
nice,
setting.
though, wouldn't it?
It has to go through the proper review, the proper coding, make sure everything is kosher with that documentation that's in the chart. Is linked directly to a code that's being used, and so we're down one person in that department, and so we've kind of we're falling back a little bit in how quickly we get things billed and dollars back in the door, and so that's an issue, and we're addressing that, and so
Right. And if it's not coded correctly, it comes back. You don't get paid a dime. Right?
Right. Oh yeah.
The whole
right.
thing comes back.
Right.
Whether it's just one little code
Right.
off, they don't pay
And
any of it.
that could put you off 30 days. So
Another 30
yeah,
days, sure,
right.
absolutely. And the coding, by the way, in case anybody forgot, it went from what 9,000 or something like that to 64,000.
Yeah, 60 something. Yeah, codes.
Kathy Weldon was in here talking about that coding, and I
Yeah.
thought, are you kidding me? That's crazy. You
Yeah.
know, but that's what they have to do, and so that's why there's a lot of questions asked of you when you get admitted, and that's
Oh, yeah.
all goes into the coding. So it's unfortunate that you have to go through some of that, but that's what's being required for
Yeah.
the hospital to be reimbursed. So you definitely have to do that.
And-
but even 59 days net in AR is not terrible when you talk about a hospital because of the length of what you have to do. It's not an automatic. It's not a one-day billing cycle to where you can get the information and get out one day. That usually does not happen.
Right.
You have to compile the information, then get the billing out. So anyway, it takes a little bit longer than that. So 59 days. I was always amazed, that when I started seeing 40 days, I'm thinking that's insane how you get 40 days at times. But a lot of that all depends on the amount of dollars that are received.
Yes.
So-
and that is the key right there is, there's a calculation there, but are you going from gross receivables? Are you going from net receivables? And how are you reporting those net receivables? Because that is
Exactly.
very important. And
Exactly.
so I think there's a somewhat of a small difference between the way that our auditors calculate and we calculate on a monthly basis. Monica and I have said, hey, however they're calculating, we're going to duplicate that calculation just the way they do because it does make a difference. And so
Sure.
you'll see in the audit report next year there's a difference between how we are reporting and we're going to go back and really detail that. So
Very good. All
Yep.
right. And then, the bottom line is that the CDs just still ain't bringing much.
Yeah.
But better. Well,
Right.
Not
Right.
much. But not much. Somewhere you can invest your money. Has to be a safe investment. Okay. Very good. Debbie Hines gave a report about the patient engagement quality report, and pretty good report there.
it was a good report.
Very
we
good report.
went through the H caps and we when you look at the inpatient
You need to tell
inpatient
people what H
caps are the
is.
inpatient
They don't know what that
the
is.
inpatient satisfaction surveys. So it's built on a 27 question survey,
Okay.
and it's broke down into categories or what they call composite. So there's a composite 1 through I think 7 or 10 or so many of these, and again made up of a composite of questions, and so some of the things they look at is communication with nurses, communication with physicians, responsiveness of our staff, how quickly we're responding, and so there's a lot of those things. Medications, are we discussing their medications? Are we discussing their discharge? When they get ready to go home, or if they're going to a nursing home, if they're going to a skilled nursing facility, if for some reason they're going to one. Are we communicating that well? And so as they go through and they're asked these 27 questions, and by the way, we do that by phone. It's an automated phone call, and sometimes you don't get the response you want with an automated phone call.
I understand that.
But Medicare, CMS is very, very strict on how these surveys get completed and get sent out. And so they're looking at, it has to be a third party, and it could be you, but you'd have to be certified specifically for doing age caps, and then you probably go through some huge review to make sure that you are following audit.
Right.
You're following those procedures just to the T. For us, it makes more sense to have a third party. Again,
Right. You had to have a total separation of services.
There is just a total separation. And so we look at that. But again, at the end of all of this survey, you hope to come out of that. They do this, they rate you on a star rating.
Right.
And so, again, if you get a 5 out of 5, that's 5-star. That is excellent. You are an excellent facility. 4 is an above average, 3 is average, and then so on. The criteria, and we've talked about this before too, the criteria is that you have to have 100 responses in a quarter, okay? But for us to have 100 responses in a quarter, that's a high percentage, and right about above 30-some%. And it just depends, because if we have more discharges, okay, so to get 100, that's a little bit lower percentage,
Right.
Yet you're looking at that 100, and it's been very difficult to get that 100.
Right. Because the last quarter we didn't get it.
We didn't get it. We got 90. It was in the high, 90. It was high 90s, and so we walked away without a star rating. And so, and it's very difficult, because when people go out and they're looking at facilities and where do I want to go for this or that or whatever,
have a star rating.
we don't have a star rating. It says NA, and it's not applicable, but it is applicable.
Yeah.
And that
doesn't
really
mean not available.
Yes, it's not applicable. It is applicable, and it is not. I mean, it really is a.
It's not a fair assessment.
No, it is not a fair assessment. And so as we start looking at that, but this quarter, we got 102 replies,
Right.
which means we're available to get a star rating.
And you got 4.
And we got a 4-star rating.
There you
So we are above average facility. And
There you
so,
go.
again, that's something we want to promote. We want people to know, because when you go out there, I think we're going to use this. And there was one other month that we got a 4-star rating as well. And we are going to look at those results compared to these results. And we're going to say, in our minds, if our results are staying this way or getting a little bit better, we're between 4 and 5-star. We know that. And so for us in-house, that's the way we're going to look at it. We're still going to push CMS to lower that threshold of 100, and maybe you want to say a response rate of 25% or 30% or whatever they want to have a response rate. But the volume, even though our response rate could be a whole lot better than these bigger hospitals, because we have so few patients,
Right.
it doesn't hit
Much
that
better
100. Doesn't
yeah.
hit that minimum, that
Yeah.
threshold. So anyway,
I mean, just for example, I'm just going to just give you one, because I know we don't have a lot of time here, Kasey, but it says, responsiveness of hospital staff, and Salem Hospital gets an 81%. The national average is 70,
yes,
and the state average is 68. You get 81%. You're 13% better than the state average, and yet if you don't get enough responses, you get an NA.
yes.
Now, see, that's not fair.
Right.
That's not a fair assessment. If you get good marks like that, you should not be penalized because you're a smaller hospital. That's what
Yeah.
you're doing. You're getting
Yeah.
penalized. So, but anyway, I just wanted to point that one out. I mean, we could go through a bunch of these, but
Sure.
we just want to let people know that your Salem Hospital, actually, in every single category where it needed to be, okay, like the national average, you're within, I want to say within 2% above or below for most of them. I don't see, and we were above on many of them, over 2%.
Mm-hmm.
But if you're below it by about, 1% or 2%. That's
Yes.
it. So you're basically even with the state or national average on those areas. But in some of the other areas, you're way over.
Yeah.
So, that personal care is something you can't always get at a big
No.
hospital.
No.
You may not get much personal care at all because you're a number.
Yeah.
Have you ever remember
Yeah.
Bob Seger, feel like a number?
Yes.
Go to one of them huge hospitals. You'll feel like a number. All right, very good. And I know we need to kind of move because you have to get out of here in just a little bit. But again, the 4-star rating, outstanding for the hospital. Congratulations on
Yeah,
that.
thank
I
you.
know that that's a great achievement for our hospital, and to have that show up on the.
Well, we have a great staff, and
Yeah.
they do what they can, and we
and we're
we
still
want to
looking
we
get
want
better.
to and we want to stick to that. Every patient, every encounter, every time, and try to give the best high quality care that we can.
Right.
So,
All right, community health. Yeah, right. I used to do this for the community health needs assessment update. The hospital has had a few of these surveys go out.
Mhm.
This is now the third one you're getting ready to work
Yes.
on, right?
yes.
And that'll be out in 2019. So, hospital has partnered up with Healthy Dent County, and you guys really have done a good job of putting out the information that people need to fill out to get it back to you. And in this 2016, they had focus projects of stroke education, doing about regarding prevention of substance use.
Yes.
Because that's everywhere. That's kind of big
Oh,
right
yeah.
now.
Yeah.
And then compliance with hypertensive and statin medications. People may say, well, what is that? Well, a lot of that's blood pressure medications
Yes.
and different things
Yeah.
of that nature. And a lot of people, don't understand it. Some of that can be dangerous. You don't want to be
Sure.
taking too much of that. And then education regarding effects of obesity towards your overall health. Because it may not sound like much, but you know what? It can lead to diabetes. It can lead to a problem. It can lead to heart disease. I
heart
mean, there's a lot of
disease,
different
lots-
things
lots
that's
of
out there.
things.
So anyway, they partnered back in 2016, got this done, created some clinics and different things to try and address
Yes.
some of those issues.
Yes.
They're
A lot
gonna-
of education.
a
There's
lot of education.
A lot of
So-
education.
So they're going to get together again for the 2019 survey. So they'll be going over a lot of different things, see how they've met some of these goals, what are they doing, or some of them they still need to be addressed, may need to be continued. But
Yes.
they'll definitely have another survey coming out, and you'll be able to put your 2 cents in.
Yes, and I will tell you, just like the HCAP survey and the number of questions, 27 questions, we did receive a list of questions from Missouri Hospital Association, but that comes from the IRS and CMS because it's an IRS requirement that
Right.
we have this health needs assessment. 51 questions, and we're gonna pull those back a little bit. I mean, to ask everybody 51
Well,
questions.
The
is
first year
just-
was
yeah,
like
oh.
5 or 8 pages long.
Yes,
It's,
yes. And that's, to me, that's unrealistic. There's probably some duplication of questions or questions that are very similar but
yeah.
asked in a different way. And I think we're gonna try and tailor that a little bit back. And if we can keep it under 25, I think that's what we're gonna shoot for. But
Yeah, that'd be good.
yeah,
Very good.
and we will make those available physically at certain events going on, but we're going to be using
online, Facebook,
yeah,
different ways.
social media. But
Yeah.
We're doing everything we
do
can that
anything.
way. And
yeah, but there will
and-
be some at pharmacies. I know you guys have always put them in pharmacies. So
Yes.
when people go get their
Yes.
prescriptions, they can pick it up. Get the
Yes.
different things there. Also at SMDH Family Medicine, many of the doctor's offices
Yes.
have them as well.
Yep.
So, be able to pick those up. It's just a health needs assessment. It'll also be at the community center at the Armory, but don't need to worry about it yet because they haven't got it ready to go. So
Nope.
don't be looking for it because it won't be there. Not yet. All right, let's really quick summarize the hospital auxiliary. Obviously, they had 10 members at your meeting October 2nd. We've got the Shoe Roads production coming up next Tuesday.
Yes.
So you can go get some new shoes, Kasey. I tell you, there's some nice pumps. I saw it would be perfect for you.
yes,
Yeah, I know it. And then the Pink Out Mammography fundraiser at the October 12th football game. A little bit rainy. Not as good a crowd as we hoped to
No.
get. A little cold, a little bit wet and
Yes.
misty, but we did want to salute all those survivors that did show up and be part of the
Yes,
process.
yes.
It was a wonderful night.
And a rainy night. I mean, we had almost all of them show up, and it was a
it was
horrible
raw
night. Yeah,
night,
it
let's
was
put
it
that
was
way.
wrong. Yep.
Yeah, but anyway, very good. So Hospital Auxiliary, again, we tip our cap. They'll meet again on November 6th. It's always the first Tuesday at the community center.
Yep.
And lunch is on Kasey.
Yes.
So if you want to be a part of the auxiliary, check that out. Now, the Hospital Foundation, they want to remind everybody Dancing with the Salem Stars will be January 26th. It got moved back because of the City Hall Auditorium's construction work.
Yes.
So it's got moved to Salem High School gym, and they've got to kind of schedule that all around basketball at that time of year, you know.
Yes.
So January 26th, they'll have that. And, of course, so we wish them the very best. Everybody's met. The dancers have all gotten together, the
Yes.
males, the females, and now they're getting ready to practice.
Getting them together, getting to practice. I mean, you know how important that is.
Well, you got to practice. And the
Yeah.
problem is finding some of the time. But they actually met on October 4th, so it gives them a good almost 3 months
Yeah.
to practice with holidays in there as well. Because sometimes
Oh, yeah.
family matters, you just can't get away.
No.
It didn't matter to me. I did it on Thanksgiving. So,
Yep.
yeah, that's the only time I could. Actually, it was thank goodness there was a Thanksgiving holiday in there before the
Right.
last one. Otherwise, I don't know what I would have done. All right, the ND structure, Hospital Foundation, is still waiting for their state tax exemption. You need a form from the IRS, from the federal government to say, yes, you are, so they can go to the state. That has not been received yet, or has it been?
No,
in the last
no,
day
no,
or two?
no.
Okay.
Has not.
Okay, and the Grant Oversight Committee also met. They're still applying for grants, and there's still grants to be had out there. But now
Yes.
that you've got the foundation changing, those grants will be much more accessible.
Yes, yes, and again, we meet a little bit later. We'll talk about strategic planning for the hospital, and the foundation is definitely in that process too. And so we'll have to include them in, and you know, as we get looking to programs that we're going to grow or begin certain programs, there could be grant funds available. And again, the strategic planning piece lets us have a little bit more structure to planning those services, those programs, or equipment that we need for those programs, and we can start applying for things.
I call it flexibility. Now
Yes.
you have some flexibility where
Yes.
before you had none.
Right.
Okay.
Right.
And it doesn't mean you're going to get every grant, which, by the way, the MFH grant that they had hoped to
Yes.
get, there would be a working partnership with Healthy Dent County and stuff that did not go through.
No.
And they're going to reapply, you know, because
Yes.
you just because you got shut down one time doesn't mean you can't reapply. You can. It's just you need to have a program that's going to catch their eye and
Yes.
stand out to them.
Yes.
That's what they want to see.
Yes. This was the Opportunities Grant, the Missouri Foundation for Health Opportunity Grant. They have different types of grants. We are actually going to apply under the Access Grant. And I think the Opportunities Grant, this was not as unique of a service or a unique opportunity as they would,
In their eyes.
Yeah, in their eyes. Definitely something that's needed in the community. And again, that was having somebody in the ER, having somebody in the clinic, and somebody stationed at Healthy Dent County to help with social needs of patients and getting patients established with primary care and doing follow-up at that primary care level.
Right.
On, chronic disease. We have lots of those patients coming in the ER, and that's where they receive their care.
Right. And
We need to transition them out of there into the right level of care, right care, right time, and again, they may have other needs, and that's where the Healthy Dent County portion of that comes into play. That other programs within the community that are available to help those, we need to get them help. So
You know, one of the things, Kasey, that when you apply for these grants and these people do not know your situation, they're not from Dent County. They're
Right.
not from small towns.
Right.
Most of them are from St. Louis or Jeff City or Columbia, and they'll get together when they determine these grants. They're not quite sure. Well, that doesn't, in their area, they don't have that problem.
right.
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 So, but our area, we have that issue. So
Yes.
they are not familiar with it. So to them, it doesn't sound like a big deal. But in our area, it actually is a big deal.
deal.
So
Yeah.
you may have to just approach that in a different way. All right, we want to remind everybody, obviously the hospital has been doing a number of different things. We mentioned the Pink Out, Rose Island Trout Derby, health screenings, 400 total, huh?
Yeah.
That's not a bad total.
No, that's
good.
good. That is good.
That's good. That's
That is
above
good.
and beyond what we had here in the first couple. So
Sure,
way above.
sure.
And I'm glad because
Sure.
we had a little bit of a downtake in that one, which didn't make any sense to
Right.
me at all. Well, we have moved the dates a little bit. That might have messed people up a little bit. However, I do
Yes.
want to remind everybody, and we have been reminding everybody, we're going to go back on Facebook again, the hospital's offering 50 free mammograms. Now, we have got a few people that have gotten signed up. I talked to Julie yesterday. There's still plenty of free mammograms. If you're 40 years of age and older, and you're underinsured or uninsured, call her. 729-6626. Ask for Julie Malone. They'll get you to her, and you can get a free mammogram. It's
Yes.
that simple.
Yes.
She will tell you. She'll do everything for you. All you need to do is call and set up the appointment. Now, if you can't do it this Friday, and they've still got a bunch of openings this Friday, I say a bunch, probably about 8 to 10, but it's still a bunch. You can get it for the rest of the month. She will work you in. So don't just say, well, I can't make it Friday, so I'm going to give up. No. Call her, get that done. Guys, this is an excellent opportunity. It's all part of Breast Cancer Awareness Month. Can't stress it any much more better than that. It's a free mammogram. Ladies, if you've not had one ever, or if you haven't had one in maybe 20 or 30 years and you needed to get one, this is your time. Get in touch with Julie, 729-6626. Ask for Julie Malone, and she will guide you through the whole process. There's nothing to be afraid of. This new machine does a great job. I won't say it's totally painless. But it's not as uncomfortable as they used to be. I've been told that from a number of people. So, especially one who tried it and said nothing like the old ones used to be. Okay, so anyway, wanted to put that out there. Also, a DEA National Take Back Day is coming up on the 27th.
Yes.
Up at Riverways Federal Credit Union, 10 to 2. So I wanted to do that. We're going to skip a little bit. Really just going to go quickly back. We had an outstanding opening of the mammography unit.
Yes.
I want to just touch on
Fantastic.
that. You got about 8 minutes.
I want to thank
so.
everybody in the community for
Yeah.
coming out. That was fantastic.
It was crowded.
It was a good turnout.
It was
very good turnout.
And we want to thank everybody there and done a great job. I thought very poignant. Thank you to the Mosier family and the D. Perminicos. Is that it?
Deep here, Dominicos.
D. Pier Dominicos.
Yeah.
Okay. Very good. And their contribution, and that's just it's an outstanding asset to our community.
Yes. Yes. I agree. Everything you said.
Well, you didn't want to set it at the place. I'm just reiterating what you said. But anyway, very good. Then you got the patient satisfaction survey results for the emergency department and SMDH family medicine. These are always very good. Always want to say, always very good. But every now and then you might need a little improvement somewhere.
Sure. I did want to mention on the family medicine
Yes, sir.
surveys.
Digital now?
They're digital now, and they're at the point of service. So when patients come out of the room and are on their way out, we've got a little tablet they can use, and they just fill out the surveys, and they're very important. Those are very important surveys that we want to have them fill out. For us and our mission, every encounter or every patient, every encounter, every time, that is very important. Every encounter counts. Today, although you've been established with us for 20 years, we hope that we provide you with as good a care today as we did, over the last 20 years, and every visit counts.
Or better.
Yes. So we need you to do that. Again, that's those questions, 5 or 6 questions, depending on answers. You may be asked additional questions after you answer. If we're not perfect, if we're not a 5 out of 5, let us know
Why?
what we can do.
What
we
happened?
got to know.
Yeah, what happened?
We got to know.
You can't fix it if you don't know what's broke.
For the first month, we had 181 surveys the first month, and that is fantastic. So they're using it. We hope they continue to use it every time they come in and out. It's so short that I feel like they should be able to do it
right.
in 30, 40 seconds.
Yeah, please take advantage. And every time you go, not just
Yes.
because,
No,
I
no.
did it last month, I was here, I had to bring my child back in. I'm not going to do it again. Yeah, please do it every single time
Yes.
if you would.
Yeah.
Okay, you did talk about a strategic planning meeting that's coming up this weekend, right?
Yes, this weekend we'll meet with medical staff, board members, administrative staff, and then a few others that are coming in and out. Just depending, we have a facilitator that comes in and helps us to facilitate that. Also, grant writing services. We again, foundation's a big part of this plan, and so they're going to be there too.
Sure.
And so a lot of those things. So.
All right, very good. And so that's all going to be happening this weekend. Also in new business, the SMDH Long-Term Care Survey. State of Missouri decided to do their survey with you.
Yeah,
That's always fun.
It is. Well, they've got a new survey process,
Right.
and it's just they come in. They used to come in. The first place they would go is administration, and we'd have kind of an interview, kind of a discussion about things. That no longer is part of their
Never
survey.
saw them, did you?
They come in and they go.
Long-term care.
They go right to the source, and we had somebody immediately go to long-term care, immediately go to dietary, and immediately say, start going throughout the facility, looking at life safety code or the code, the building code
Right.
for healthcare facilities. So did that, and there for two complete days. And when they left, we ended up getting, or at least this is the informal
You haven't got the
reviews.
paperwork back.
Right, we haven't got it yet. They've got 10 days to get us, 10 working days to get us that. And then once we get that final review, we have 10 calendar days to get them back our plan of correction.
Right.
So, but there were some things that were noted while they were here, and we fixed them while they were here, and so they were happy with the fix, and they were happy with the process, and that worked out. We ended up getting one, what we call a K tag,
Yeah.
okay, and that has to do with the life safety code, the building code that we had review that we had, and that had to do with oxygen. And how we store our oxygen tanks, and the education that goes with that, storage of tanks, and the use of those tanks. So, again, something we're going to include that education across the board in the hospital. That's definitely,
fixable.
that's fixable. So, we're going to do that. And then the last thing, again, they just had some tips for long-term care altogether, and then they also had some tips for the dietary department. So some of those things, we will see some changes in our processes just from those suggestions. So
Okay. Very good. That's an excellent survey. Excellent
Yes.
survey. Very good. Okay, another new business. We get to buy a treadmill.
Sure.
Woo-ha.
we got a replacement treadmill for rehab. So
We have. They've been wearing out the treadmill. I can tell you that much.
yeah, it's gonna be it's.
Okay, very good.
Yeah.
This is a performance health treadmill. It's the model is the Physio Mill, and this is a rehab treadmill. So, I mean, people say, "Wow, man, that's a lot of money for a treadmill." It's not that kind of just go out there and buy
No.
your everyday Kmart treadmill.
No.
Okay,
It's
for $99.99.
it's healthcare grade.
It's got a lot of different stuff on it. Okay.
Yeah.
To help you with extended handrails. It's got the different speeds. It inclines. It knows when a patient's this is how intelligent some of these are. It knows when a patient's struggling. It will, especially if you're on an incline, it will drop the incline
Yes.
so that you don't
Yes.
struggle.
Yeah.
You don't hurt yourself, and that's the whole thing. $4,823, and this was a budgeted item.
Yes.
You actually save money off your budget.
Yeah.
Very good. Closed session.
Nope, didn't
Not-
do no
you had
motions.
one.
We did. We discussed many things, but we did not. There was no motions or.
Very good. So you owe me a minute. I got you done. 9:44.
Yes. All right.
Okay? Very good. Anyway, we want to thank Kasey for coming in and spending some time with us again. Don't forget to take advantage of those free mammograms going on at the hospital. They're offering them this month of October. There's a lot of openings for Friday yet still available. All you got to do is call Julie Malone, 729-6626 or 729-5917. Just ask for Julie. They will direct you to her, and then she will help you get everything done. It's just that simple.
Yes.
I know you got to hit the road. Good to see you, my
Yes.
friend. Take
Thank
care.
you.
And thank you very much, and good job this month, and thank everybody. Now, we will have a little different schedule for November and December.
Yes.
We always do, and so
Yes.
we'll be meeting a little different time. So
Yes.
we'll be letting you know when Kasey will be back in. In the meantime, sir, thank you very much for stopping in.
Thank you, Stan.